Welcome to the Grow Your Practice podcast. Hi, I'm your host, Chad Madden, owner of Madden Physical Therapy and Breakthrough. Join me each week as we dive into the best practices, systems, principles, tips, and tricks to help you grow your private practice. How can I improve my payer mix? In this episode, we're going to talk through this very common challenge and how you can think through as a practice owner, attracting more of your better payers and less of your lowest payers, and doing so in an ethical way, because that ultimately that is the challenge, right? So the benefits of doing this the right way, many of us, especially if we're still accepting low payers, we're seeing patients for free or we're literally losing money. We're not generating enough profitability and enough of a margin in order to survive. So that's a problem. When you do this the right way, you can improve your margin of safety, improve your profitability. You're going to be more valuable and impactful within the community. You're going to be able to keep your doors open. You're going to be able to compensate your team and ultimately retain them better because you have a better margin of safety. And also you're going to be able to invest back into your clinic, right? You'll be able to invest more in more, better, newer equipment, better facilities, etc. When I think about this challenge, and what most owners are surprised with is that the answer to improving payer mix, yes, we can do things directly with the payer. So we can figure out how to renegotiate rates and we can drop a low payer, right? We can go out of network. So that's two options. One of the most powerful options is marketing, right? Increasing the demand for our service amongst the type of patient that we want to see more of. So, let's say our cost to provide a single visit is $80 and we're getting $70 for that visit, right? We're losing money on that patient. So years ago, I found myself in this situation. We had a payer, this is in the late 2000s, that paid $48 a visit. Absolutely brutal. And, when I had decided to go into private practice years before, I had committed to saying, regardless of what an insurance company pays me, I am going to see that patient, right? Even if it's at a loss, which in this case, for this insurance company, it absolutely was a loss. Well, when I first opened up, I was relying on physician referrals. And the common belief system at that time is, I couldn't turn around, go out of network with that low payer, even though they only represented 5 or 10%, because if somehow, a physician who was used to sending patients to me, let's say Dr. Kelly, I'll use Dr. Kelly. So Dr. Kelly's referring patients to me, and now all of a sudden I go out of network with somebody that he's typically sends me. Well, now he's going to send that patient somewhere else, right? And ultimately, there's a fear of loss that we're going to lose Dr. Kelly's referrals because now I'm out of network with this payer that I'm honestly having to pay to see that patient, right? So quite a conundrum, ethical conundrum. And, what happened for me is once we started marketing direct to the consumer and relying less on physician referrals, kind of had this aha moment of like, oh, I can actually influence my payer mix here with these other new patient channels. So that was the ethical dilemma. Do I go out of network? What do we do in this situation? Do we create a bad situation relationship with the referral source? Now they have to send, they can only send me, let's say, Blue Cross and Blue Shield patients, and somebody who's a lower payer, they have to send somewhere else. Like that creates a really bad taste for everybody across the board. But you have to keep that thought in mind, right? Which most of us have, especially in private practice where we were relying on physician referrals. And this is the older model, physician dependent. And now when we start going direct to consumer, it doesn't mean that we can't be smarter with our marketing, right? So we can take that old system, that old value system, and say, okay, I'm going to see anybody the physician sends me because I'm at the whim of the physician and they have their hand on me. They really have control of the practice and they have hold of the driver's wheel, right? The steering wheel. And now when I go direct to consumer, I'm going to bring those old values with me. That is not how this works. And again, probably 2010, 2011, start to have some really good realizations around this, that there was a better way. And I didn't have to bring that with me, that, the belief of the physician referral and those patterns, I didn't have to bring that over, that same thought process in direct to consumer marketing. So the solution was discerning the 5 new patient pathways, right? We have this framework we can think through. How do we get new patients into our practice? At that time, I thought it was 3 ways: patient list, cold traffic marketing, and physicians. They were the 3 things that's all the farther I knew to break it down. down. Over the last 10, 15 years, that's evolved into the 5 new patient pathways, which at the lowest level, the lowest hanging fruit, we have reactivations. Next level up, we have word of mouth referrals. Next level up, we have physician or other professional referrals, right? Nurse practitioners, etc. Next level up, we have partners. So these are organizations within our community who can promote our services to their list, their member lists, their customer list. And then finally, we have cold traffic. So there are the 5 new patient pathways. And if we break each one of these down, with reactivation, can we influence our payer mix? Surprise, we can. And I'll share with you a quick and easy way how to do that, how you can start thinking through that. And I'll share I think it's 8 different ways that we can improve our payer mix with reactivations. Next level up, we have word of mouth referrals. Could you imagine working with a patient and saying, okay, Mary, who else do you know who could use our help, right? And, if you know somebody else that needs our service, please send, and by the way, if they have this insurance, XYZ insurance, make sure they don't come here because we don't accept that insurance, right? You would never do that. So we can't do it with word of mouth referrals. Can influence payer mix well. Next level up would be physicians. Same idea there. We already know that's a huge roadblock, a huge struggle to talk with a physician and say, by the way, send us Blue Cross Blue Shield patients, but don't send us insurance company XYZ, right? You're never going to do that. Next level up, we have partners. Of course, we can, here's the easiest way to think about this. Who's your best payer? Private insurance payer. And employers in your area, largest employers in your area that offer that insurance as a benefit to their employees. You should know who that is. You likely already have that information within your patient list, especially if you're collecting employer name, right? Because you can go through your patient list and say, okay, Mary has, let's say it's Blue Shield, and she's employed by, I'll use somebody local here, Ollie's. Great. So Ollie's gives her this benefit. Great. Now I know that that employer offers Blue Shield to their employees, right? Very, very easy to figure that out with your patient list. If you're not collecting employer names, might be a little more challenging, but I'm sure your local chamber of commerce. We used to use something very similar. It was Central Business Journal published a lot of lists where we could get that information. And then the final level, so we can do it with reactivations, we can do it with partners, and then the final level is cold traffic marketing. I'll give you a little wrinkle here in a second about how you can think about influence. And by the way, it's the first thing that I did. Once I discovered, direct to consumer marketing and figured out that I could influence my payer mix and influence our profitability with cold traffic marketing, that was a game changer for us. So yeah, easy to do and really easy to think through. I'll give you the simplest way that you can think about this without getting into the advanced stuff where we really have to get into the weeds here. So, think about who your ideal customer, they call this the ICP in any marketing channel, but who's your ideal client profile or your ideal patient profile? Think through that. For us, it's a 45 to 64-year-old family-oriented female. That means she's likely married, likely a mother, possibly a grandmother, and definitely a daughter, right? So in that case, we know within that demographic, she is the number one consumer in the world. If she's high school educated and 49 years old, and if she's college educated, it's 53 years old. So that means she directs more dollars than any other human being in the world. She schedules roughly 70% of all medical appointments for her family, and that includes her partner, her spouse, husband, potentially her children, also her grandchildren, and if she's involved in their care, likely her parents. She's social. And we throw one more caveat in there. We're looking for household income, $100,000 a year or more. And all of that is very easy to find. I use stands for everydoordirectmail.usps. It's a free tool. It's Every Door Direct Mail, United States Postal Service, but eddm.usps.com. And you can go there and go through any neighborhood in the country, any zip code, every postal route, and see the average household income for that postal route. So a lot that you can do to hedge your bet as you're marketing and we typically look for where that target market lives relative to our 5 or 10 mile radius around the clinic, and then where they shop. So where do they shop? They're going to Target, they're going to Kohl's, they're going to Hobby Lobby. And all of those are, within a half a mile from where I'm recording this right now, from our main original office. They're going to Starbucks. That's what you're looking for. So think through your ideal patient profile. And then what typically gets in the way for most owners is this self-limiting belief around, I want to serve everyone, right? In business, as a practice owner, we are constantly balancing 2 things. One is relationships. And that's where, it's relationships with our patients patients, relationships with our employees, our team members, relationships with any stakeholders that we have in the business, which could be employees, could be other partners, could be our partners at home, right? Our family. But we tend to think about and gravitate towards taking care of relationships. That's why we became clinicians, right? Probably not to become a billionaire, right? That's not on your radar when you're 22 years old going to grad school. You became a clinician because you wanted to help people, right? Because you're thinking about relationships. On the other end, we have productivity. So this is where money comes in. This is where statistics comes in. This is where metrics and tracking and all of that. Most of us, when we first come out of school, are fairly poor at that. We're not great, right? We don't emphasize. If you've ever worked in a situation where you're working with somebody who's only focused on the numbers, you know what that feels like, right? Not great. So for most of us, we're trying to balance those two things, right? If we have production and math and profit and finance only, we get burnt out pretty quick.
Attention private practice owners, are you ready to thrive in 2025? Join us for State of PT, a free virtual event on February 27th from 10 a.m. to 3 p.m. Eastern. Spend the day with industry experts discussing the new rules of private practice growth in 2025. Secure your complimentary spot now at stateofpt.com or click on the link in the description. Now, back to the episode.
If we have relationships only, we're in jeopardy of going out of business, right? So we're constantly balancing these two things. That's the challenge. And again, unfortunately, most of us are wired where we only think about the relationships. Even I've seen practice owners go out of business because they were only focused on the relationships and they could never bring in that other component or didn't have somebody else to complement them. Along those lines, the thought exercise I went through back in 2010, 2011, once I figured out with direct-to-consumer marketing, I was allowed to choose who I wanted to attract, right? I could say 45 to 64-year-old family-oriented female who has $100,000 a year household income on average and has Blue Shield, right? I can say that, right? And I can go find that person and market specifically to them in my community. And the thought exercise that I went through was, what would my practice look like? Remember, we have this low payer who's like 10% of our payer mix. What if we had 100% of only my best payer, right? What if 100% of our practice, and at the time, I'm going to guess we were seeing like 400, 500 visits a week for our entire practice. What if we had 500 visits a week of nothing but Highmark Blue Shield? How amazing would that be, right? And over the years, what we've done is we've gone to those 3 new patient pathways that we can control: reactivations, partners, and also cold traffic, and have slowly migrated an improvement in our payer mix around those lines. So it's not 100%, but we're moving in that direction. At the same time, we were able to get out of network with 3 of our lowest payers over the last 10 years or so. So that's helped tremendously because we created enough demand amongst those other channels. So how do you do it? How do you apply it? Well, with reactivations, here is the easiest way. You could go through your EMR, and this is going to take a little bit of legwork, a little bit of time, but if you don't have the financial resources to market your practice, this is the easiest, lowest hanging fruit. It just takes time. So a little bit of elbow grease, a little bit of blood, sweat, and tears. Go through your EMR, whatever your highest payer is. Go through that list first. So go through, every single patient within your EMR, and especially focus on those that have the best payer. So again, let's say ours is Highmark Blue Shield. I'm going down through and I see Mary Allison, right? Let's say that's the first patient I come across. So then I can say, okay, with this pay, I know she had Highmark Blue Shield in the past when I saw her last year, highly likely to still have that insurance. Okay, so I can reach out to Mary. Hey, Mary, this is Chad over at Madden and Gilbert Physical Therapy. It's been about a year since I saw you for your shoulder. How are you? Right? We know when we text or email that message, the response rate is about 90%, especially if she achieved her goals and she graduated from my care. Highly likely she's going to respond, right? So there's 2 things that she can say. One is, I'm doing great. I still do my shoulder exercises. Haven't had any trouble at all, right? The other one is, funny, you should reach out to me. My shoulder's actually bothering me again, right? So the first one, I'm not having any pain. Then we have to ask a follow-up question, which is, what else is bothering you, right? Glad to hear about your shoulder. What else is bothering you? We can go that route, right? We're looking for a need here in reactivation. If she says, my shoulder's bothering me again, it's like, okay, I looked ahead in the schedule. I have an appointment open next Tuesday at 8:30. Do you want that appointment? Does that work for you, right? So now we're having a conversation, a 2-way conversation with Mary to get her the help that she she needs. And all we did was reach out, right? But we could do that. And you can imagine fairly quickly, if we're running that, especially for our highest payers, that's going to influence our payer mix. We're going to be reactivating the portion of our patient list that has the highest and best payers. That's number one. Number two, for our partners, I shared the thing about employment, right? We could go through and we start going through our EMR. We're looking for Highmark. We see Mary Allison. We take a look, and Mary Allison works at the Pennsylvania State Credit Union. Great. Now we know the Pennsylvania State Credit Union offers Highmark to their employees. So now what we could do is one of several things. What I like to do is find the HR director. Do I know somebody who knows the HR director? Or I can reach out to Mary and ask for an introduction. I don't want to cold call. I'd prefer to get a warm introduction from a patient to the HR director, and then I'm going to ask some basic questions. I'm going to set up partner events. If they already are hosting health fairs, lunch and learns, etc., I'm just going to plug into that, right? I don't want to reinvent the wheel. I just want to plug into what they're doing, bring value to the table, to their team members, which they're already doing, right? And now it's kind of great. So we've had a long-standing 20+ year relationship with a credit union. And they do host lunch and learns. They professionally record them, and then their employees get compensated, rewarded to watch the lunch and learn. So wrap your head around that, right? Like, so a little bit of work. We are going in as the position as the authority celebrity expert for certain conditions, and we've seen hundreds of patients from that relationship over the years. So, and if you get 4 of those or 6 of those or 10 of those relationships in your area, you're going to be, dramatically influencing your payer mix there, even with one. So that's payer mix. The final one that I'll leave you with, which is probably the toughest to wrap your head around and comprehend at the beginning, is this idea of, can we go to the cold market and segment? Well, years ago, going back to like 2016, 2017, with some social media platforms, you could do that. So like in the early days, you were allowed to segment based on household income, which was crazy. And that is gone, right? So as social media platforms mature, your ability to segment goes away. However, we started inverting it and looking at it from the other end. And what we noticed was like, okay, let's think about this. If we can no longer segment doing cold traffic marketing based on household income and demographics, is there any data that we have where we could start hedging our bet a little bit better? And we thought it was diagnosis. So we went to our EMR, we broke down all the different diagnoses, the most common diagnoses that we saw. So we had everything on there from like knee pain, hip pain, lumbopelvic issues, thoracic issues, cervical spine, shoulder, upper extremity, cervical spine, if I didn't say that already, cervicogenic headaches, vestibular issues, BPPV, VOR deficits, gait training, etc. So we had all of these diagnoses, the most common diagnoses that we were seeing in the clinic. And then we said, okay, what is the value on average of this patient coming in, right? And we can see that within our EMR. And so just segmenting by diagnosis. And I know for us, we pride ourselves on a lot of things. One of them is being a manual therapy clinic. Another thing that we treat quite a bit is vestibular BPPV patients, is one segment of the vestibular patients we see. However, we know on average, we're going to see that BPPV patient for 2 or 3 visits, right? So you're never going to see an ad for Madden and Gilbert Physical Therapy advertising for BPPV on Facebook, right? It just doesn't make sense, because that person's going to come in. We're going to see them for maybe 3 visits. We're going to get $250 for that. And there's no way that I can make that work, right? And that person's feeling better and they're out the door. Now, I know there's an argument to be made. Well, they might return for something else in the future. That's fine. I like a little bit quicker turnaround on our monetary investment for marketing. And if we're going to invest to attract attention, I want it to be on something that is going to be a higher plan of care value on average. So some clinics, it might be back pain. Other clinics might be shoulder pain. For us, the easy winner is shoulder. The second for us is pelvic floor, right? So anytime that we're advertising for those 2 things, we're going to get a healthy plan of care coming through. That person is highly likely to complete their plan of care, achieve their goals, etc. And it makes financial sense for us as well. So we can influence our payer mix that way. The other thing that you can get with some diagnoses, like with our pelvic floor, is we target new and expecting mothers. So that influences the payer mix as well, especially in situations where you have a very high Medicare population. For you, if Medicare is your number 1 payer, that's easy. Then you're going to go along the lines of arthritis, or especially like hip and knee arthritis, rotator cuff issues, etc. So think about diagnosis, and that's another way that you can influence your payer mix. So just to recap here, we talked about the challenge of how can I improve my payer mix beyond renegotiating beyond dropping a low payer. What else can I do? To me, all roads lead to marketing there. So we can attract more of the higher payer and a lower percentage of our lower payer. The benefits of doing that, we're improving our margin of safety. We can take care of our team members better, compensate our team, better retention, et cetera. We can invest in our facilities as well, right? Better facilities, better equipment. And, I also shared with you how, like, in the very beginning, we were primarily a physician referral based clinic. And then as we went direct to consumer, we dropped that old self-limiting belief of we couldn't go out of network with anybody. We couldn't influence our payer mix in any way. And we were just at the whim of the physician. And then we became a lot more positive when we went over to direct to consumer and started implementing and thinking about the 5 new patient pathways. I also shared the framework of how we think through identifying an ideal patient profile or an ideal ICP, ideal client profile. And then finally, we walk through, the self-limiting belief where I have to serve everyone equally. And what we replace that with is it's okay if I market and attract a better paying patient. As always, very much hope you enjoyed this episode. One quick final thing for you. We do have a virtual summit coming up. It is going to be on February 27th. I think we have 6, maybe 7 hours action packed. We're going to start with the state of PT, and we're going to talk about private practice specifically for physical therapy. So I know we have lots of listeners in functional med and chiropractic, occupational therapy, speech therapy, etc., behavioral health specialists on this podcast. That event on February 27th will be specifically around the state of private practice physical therapy, but you're more than welcome to join there. We will post a link in the show notes for you for that. Again, that'll be on February 27th. I think we have over 20 other speakers that are going to be on panels. So you'll not just be hearing from me. I know Carl Mattiolo, the CEO here at Breakthrough, will be on there. You'll love it. He's going to share something that's absolutely crazy. Yeah, regarding AI. That he's been working on hard with the engineering team. So you don't want to miss that. I know Mary and Alicia from BCMS will be on there. Paul Welk, Chris Redding, lots of other experts are going to be on there as well. So very much looking forward to that. We have an awesome dais. The team worked really hard here to put that together. Again, that'll be on February 27th, nearly an all-day event. I think we start at 9:30 and go till 4, something like that. Anyhow, hope you very much enjoyed this episode, and I'll see you on the next.